looking for pulsations and thrills, that's both of those, what you're doing is palpation, you follow me? So once you come down through and you find that second rib, second intercostal space along that sternal border, and you've got your finger pads there, then you don't have to break it up like I just did, which is, okay, there's the aortic, here's the pulmonic, or you can do aortic and no pulsations and no thrills. Pulmonic, there's my pulmonic, no pulsations and no, see how I'm doing that sideways thing? And no thrills, all right? As opposed to, you know, this kind of thing going down through there, all right? You with me? And so you can combine these two steps. Am I making sense to you? So you can say, oh, there's the third intercostal space, no pulsations, and no thrill. And you're doing this as you're finding your locations. What's the point of this? As you're finding your locations for pulsations, thrills, you're also kind of like mapping out where you're going to listen real shortly. Aortic, pulmonic, curves, point, fourth intercostal, tricuspid, and baby steps over your mitral. You've laid it out for yourself. Do you follow me? Does that make sense? Yeah? So you can combine those steps. You do not have to say, okay, found my aortic, found my pulmonic, found my herbs, found my fourth intercostal, found my tricuspid, and found my mitral. Okay, now I'm going to feel if there's any pulsations or thrills, feel if there's any pulsations or thrills, feel if there's any pulsations. You can combine it all in one step, all right? I wanted to break it up so that we would say, let's just find the location first. Say, okay, I'm with them, I see where you're going with this. And then I say, now that you found the locations, let's see if there's any pulsations. And pulsations point to, you don't want pulsations up here in the base, right? Pulsations point to, what am I going to ask you? Pulsation, why, what, that's what, so what, you found pulsations up here. You've got a large heart, you've got cardiomegaly. You following? Thrills. Oh, I got a thrill. You've got what? You've got some vibration going on there from regurgitation or stenosis. There's probably going to be, when I listen, there's probably going to be a whopping murmur that I'm going to hear here. Okay? Am I making sense, you guys? All right? Now, and you can combine this next step, which is the PMI. Yeah. We're going to palpate the PMI, and the next step, that can all be combined too. It's a third step in this process, but it can be all in one fell swoop, because I did aortic, pulsations, thrills, pulsations, thrills, pulsations, thrills, pulsations, thrills, pulsations, thrills, and now I'm over here, and I'm doing pulsations, and then if I'm on the right side of the patient, it's hard to do on myself, but I suppose you can catch it from this side. That's not as polite as I like what I did before, where I come around and I do it, you know, with the pointer there. You with me? All right. So now that I'm into this area where I'm checking out the fifth intercostal space, I'm checking out for pulsations here. Those pulsations, we pay attention to the parameters. Pulsations for the PMI, location. You tell me. If the heart is not enlarged, apex, here's my apex, right? If my heart is not enlarged, what's the location of the PMI? Location should be in the fifth. Good for you. Good for you. The fifth intercostal space, mid-clavicular line, right? Fifth intercostal space, mid-clavicular line. If the heart is enlarged, and I have a few patients in the practice who have congestive heart failure, if the heart is enlarged, where does it go? It starts out toward that anterior axillary line, not the mid-clavicular line, but it starts moving toward the anterior axillary line, and it goes deeper into the sixth or seventh intercostal space. Okay? So where should it normally be? You should feel that PMI where? Location, fifth intercostal space, mid-clavicular line. The rate should be, you could now say, consistent with the pulse that I got in vital signs. Rhythm should be regular. Intensity, another word for intensity is strength. So the intensity should be strong, moderate, or weak. And the diameter should be just in that intercostal space. And just in that little space there is 1 inch or 2.5 centimeters. 1 inch or 2.5 centimeters, and I'm not asking you to measure this thing. I'm just, if it's about 1 inch, if it's only in that intercostal space, fifth intercostal space, mid-clavicular line, I'm asking you to say appropriate. Remember our backup term? Appropriate means normal, it's what it should be. We can say appropriate if it's just in that space. If you're feeling, this is one of my patients with congestive heart failure. Oh, it was so interesting. We had this over at Lifeline. I had students over there, and I saw congestive heart failure. I was just making my rounds on the whole floor, and I saw a lady with congestive heart failure, and I thought, I've got to check her out. So I went in there and asked her if I could examine, and when I did the pulsations, thrills, I was able to get pulsations everywhere. And the PMI, she put my PMI to shame. When you feel yours, you have to kind of search for it. So, oh, there it is. Yes, yes, that's strong. That's a tapping coming through. Hers was like, it was like a baby underneath there, moving his elbows around. I mean, it was significant. So when the students came in, I befriended her because I had cold hands and she had hands that were too hot, and she liked my cold hands because they cooled down her hot hands. So I would hold her hands while the student would come in, and it was just amazing to see students. As soon as they put their down here on the aortic, they go, oh wow. You know, I would normally encourage you guys to not do that, right? Oh my goodness. I would encourage you not to do that. But she was such a nice lady that she says, yeah, everybody does that. You know, so she was just one of those cool ladies that could accept that. So I didn't head the students off in advance by saying, hey, you're gonna feel pulsations throughout. She's got cardiomegaly to the max. So I don't want you to go, ooh, wow. We both kind of enjoyed the students going, for once, we enjoyed the students go, oh, wow. You know, and so that's what she gave us. But that's what you'll catch with cardiomegaly. Let's see, so intensity, no, it's a diameter thing. The diameter is appropriate, and the duration, feel your pulse, your PMI down there. Go ahead, go to your PMI and see if you can feel it. And if you can't, kind of lean off to the side there. That'll displace the heart a little bit closer to your chest. And I got a good one here. And you can feel it. If you can't catch it, guys, kind of lean off to your left-hand side a little bit, your left-hand side, and see if you can feel it coming in there. All right? And it's just doing this. I'm going to do hopefully what you're feeling. It's just kind of doing this, isn't it? Just in that intercostal space. You don't feel this big, massive thing over a bunch of intercostal spaces doing this thing, right? Lose my stuff, right? True? Okay. So when you say the duration is it's doing this. It's doing this, guys. It's doing love, dub, love, dub, love, dub, love, dub. As this does this and it contracts, those AV valves slam shut. Love, dub, love, dub. And as it's doing this, it's giving you that apex is just giving you this little tapping in that intercostal space, and that's what you're supposed to be feeling. So when you say the duration, it should be appropriate. You don't feel this thing like a baby's elbow coming through. It's just like a faint little tapping there. When I say faint, I don't mean weak. I'm just saying it's a periodic little tapping there. You're not getting this big, huge waveform coming through. So duration, it's just giving you a tap. That's it. And it's happening over systole and not over diastole. You follow me? So you're doing like a love, dub, love, dub, love, dub, love, dub. You see what I'm doing? Contracting, making the valve slam shut. Love, dub, love, dub, love, dub. That's the duration that you're getting. And so I'm not asking you to time it or anything like that. I'm just saying, hey, does that look right? Or are you getting this? Or are you getting here? What could you feel? You could be feeling this big, massive movement. And when it moves this way and it moves this way, you feel the whole thing moving around there. And that's an elongated duration that's happening over systole and diastole, and that's an inappropriate. So we can say the duration is appropriate. Am I making sense to you? Okay. From there, okay, so, and I don't think I need to, yes, I should. Okay, so fifth intercostal space, midclavicular line, we're going right about that area right there, and we're feeling where that's the DSO, rate, consistent with vital signs, rhythm is regular. What's my next parameter? I'll be looking in my notebook. What's my next one?
Intensity.
Rate, rhythm, strength, strong. Which one? What's next?
Diameter.
Diameter is appropriate. I'm just feeling it in that intercostal space, nowhere else. What else we have? Duration is appropriate. Good, thanks, you got it. All right. Any questions on that? If we're going to listen, what should we do? If we're going to really truly listen, we should be listening underneath the gown. Follow me? Did I not show you last week how to drop the stethoscope and control from the outside, right? Okay, for the sake of you guys getting to see this, I think I'm going to go on the outside so you can see exactly where I'm going. Questions?
Just a quick question. For the duration of the fifth intercostal, or I guess like pulse, do you want us to actually write down a number for that, or can we just say it's appropriate?
Just appropriate. No number. You're not keeping track of any timing or anything like that. You've already done that with the rate, rate, rhythm. You've already done that. This, I'm just saying, can you feel that little movement underneath there, or is it a huge movement that is taking a lot of time to get through there? Does that make sense?
Yes.
If I've got cardiomegaly, this thing is moving right at the beginning, it's moving at the end, and as soon as the contraction is done, it's so big, it's in constant motion. And so you're just looking for a little tap coming through there. If you've got an expanded heart, if it does any movement at all, you're feeling the whole thing. and that's an elongated duration, if you will. I'm just asking, say, that's appropriate. That's what I would normally feel. And how do you know that? Have you ever done this before? Has anybody done this before? No, so you've got nothing to compare with. But as you're starting to pick it up on yourself, saying that's what I always feel on a normal person, so I can say duration is appropriate versus inappropriate. Inappropriate is in a large heart, and that's when you would document, duration, elongated, extended, and you would document I think I've got cardiomegaly on there, or suspect enlargement of the heart. Okay, good? All right. Okay, so let's see. Oh, listening. Yeah, so we're going to listen 3 times through. And there's an economy of steps here, and let me show you how that works. Again, I'm not going to put the earpieces in, but we're going to go, and God, let me have you scooch over here so I can do the proper demonstration here. All right, so I've already sized things up. I know where the angle of Louis is at. There's an angle of Louis right there. There's the second rib. There's a second intercostal space right there. So where am I listening? You tell me, what sculptatory site is that? Orientation, pressure. Good. Aortic. Listen for a couple. Boom, boom. Boom, boom. Boom, boom. Is that right?
Mm-hmm.
Boom, boom. All right. And then from there, aortic. What are we doing? Pulmonic. What should I hear? Boom, boom. Boom, boom. Boom, boom. Now we're going to name it. Herbs. All right. And I'm still hearing boom, boom. Boom, boom. And now I'm going down to who? Fourth intercostal. Guess what's happening now? Starting to switch over, and what's getting louder now? You're starting at the boom. You're starting into that. Then we come down to the tricuspid, and guys, you're saying he didn't palpate those intercostal spaces. This is a big guess right now. And so when I do this, it's just like the lungs. I'm trying to get where I think I should be. All right. So now we're at the tricuspid, and what should the relationship be? What should I now be hearing? Boom, 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 boom. And now watch my little baby step technique. A little half step, and a little half step, and that puts me right up into the mitral auscultatory site. Is it believable? Do you see that I'm in the 5th intercostal space? I should not be closer to the anterior axillary line. I should be in the 5th intercostal space in the clavicular line. And where's that at? For women, it's the underwire. Okay, that's where you're heading for. Men, it's just the base of the pectoral muscle, the base of the pectoral muscle, all right? And there you go. Now, for economy of steps, what I do, I'm just looking for the appropriate relationship of S1, S2. Now I'm going back through and I'm listening to high-pitched sounds. And pay attention, do I hear any high-pitched extra sounds? Any high-pitched extra sounds? So where am I at? What's this called? Mitral, couple baby steps over. Where am I at now? Tricuspid. Where am I at now? Now where am I at?
Herbs.
Where am I at?
Pulmonic.
Where am I at?
Aortic.
Good. You see how that works? Don't pull that stethoscope out and start all over again. You're already there, just backtrack. Does that make sense? Now what do I have to do? Third time through is for low-pitched extra heart sounds. Low-pitched extra heart sounds. What do I have to do? Flip the stethoscope over, the head over. So, down, where am I at?
Aortic. Pulmonic. Herbs. 4th intercostal.
Tricuspid. What do I do?
Baby steps.
I'm listening to the septum. I want to hear what's going on over the septal wall. And then where I finish up?
Mitral.
The mitral auscultatory site. All right? So, one more time. What valve am I listening to here?
Aortic.
What valve?
Pulmonic. Herbs.
What am I listening to?
Pulmonic and aortic.
Aortic and pulmonic. Aortic and pulmonic. You're right. You're closer to the pulmonic, but you're listening close to aortic pulmonic. 4th intercostal. I'm getting into what? Tricuspid area, but where's the best area for tricuspid? 5th. There's tricuspid, baby steps, and now what am I listening to here?
Mitral.
Mitral auscultatory area. Okay? All right. Mitral valve prolapse. Thank you. Mitral valve prolapse. The valve shuts. Oh, I should do it this way. The ventricle contracts. The left ventricle contracts. The mitral valve slams shut. The aorta opens up to receive all that blood. Do you visualize it? Are you seeing it? All right. So, mitral valve prolapse is the valve slams shut. One of the leaflets clicks back open, so you get a little click there, and then blood regurgitates up through there, And so you get a lub, click, whoosh, and then you have the AV, the semi, excuse me, yeah, then you have the semilunar valves shut above that. So it works like this: lub, click, whoosh, and dub. All right. Where are you going to pick that up? MVP, not most valuable player. Mitral valve prolapse. Where are you going to pick that up? Say, I think the patient, the diagnosis is already there. Yes, fifth intercostal space, midclavicular line. The mitral sculptory side. You see on the chart, the patient has MVP, mitral valve prolapse. So when you're listening to the heart, if you hear that sounds over there, you're going to expect it to hear it most loudly where? Mitral valve. See how that works? That's why you need to know what these listening sites, the aortic, best for aortic, pulmonic, best for pulmonic, herbs, listening to both, aortic and pulmonic. Fourth intercostal, starting to get into the tricuspid region. Tricuspid, you are listening best at what's going on in the tricuspid valve. A couple baby steps, listening to what's going on in the septum. Mitral, that's the valve that you're hearing best at that location. Questions on that whole thing? You with me? All right. We'll talk about murmurs and what produces them, stenosis, regurgitation, and all that stuff. And just anyone think you might go into an ICU setting? An ICU setting? So if you're thinking about being an ICU type nurse, you really need to know this stuff, because you've got to be able to pick up on a patient going into acute congestive heart failure. You will have specific heart sounds that are produced with murmurs that will produce themselves as a result of that. You want to pick it up before it gets too bad. All right, so maximum intensity and any radiation. Really interestingly enough, if I've got aortic stenosis, I can hear it here, but I can also hear it up here in the carotid areas. And it makes sense because aortic, it's going that way. So radiation site, common radiation sites for aortic stenosis is you hear it here, but you also hear it up in the carotids. You hear that murmur vibrating, if you will, or sending itself enhanced up through there. On a mitral valve problem, mitral valve, oftentimes you'll hear it up here in the brachial artery. So if you come up here on the arm and you listen over the brachial artery, you can hear it up in there as well. So that's a radiation site. So when you say radiation, not only can you hear it here, but you can also hear pretty well up in here. And which one was that? Aortic what? Stenosis. Aortic stenosis is classic for being, let's say, hey, do I have aortic? Yeah, look here, I have it both. It's a classic of aortic stenosis. You've got mitral valve regurgitation. Mitral valve regurgitation. Not only do you hear it here, if it's truly mitral valve regurgitation, you also hear it where? What's a mitral valve problem? Its radiation site is where? Brachial artery. You put up in the armpit there and go over that brachial artery, then you'll hear it up in there on the brachial artery as well. Okay. Make sense? So those are all the parameters that go with the murmurs. If you hear one. If you don't, guys, in examination time, if you don't hear one, you don't have to document that you heard one. You just don't need to do that. All right, so there, and then lastly, I told you I was going to catch percussion somewhere. I don't expect you to percuss all those auscultatory sites on the lungs, front and back and sides and all that stuff, but I do want to check and see if you can percuss. And so this is where I do that. We could, the base of the heart, the true base of the heart is in the third intercostal space, fourth intercostal space, and the apex is in the fifth intercostal space. So we could percuss the full silhouette of the heart. So if I start out here in the midclavicular line, what am I going to get? A percussatory note, right? Boom, boom. What am I going to get out here in the midclavicular line in the third intercostal space? Third intercostal space, midclavicular line, I'm out here thumping. What should that percussatory note be? Resonance, good. That should be pulmonary resonance. Then as I get closer and closer to the sternum where the heart is sitting in here, it should go from resonance to? Dullness. Very good. You're getting it. You're putting it together. Dullness. And then you go, if you follow dullness for a while, and then you get along that left sternal border, and you start leaving the silhouette of the heart, and now you get back into what? Resonance. So in a third intercostal space, you're looking for midclavicular line. You're looking for pulmonary resonance, and as you work across and you start getting close to the sternum, the sternal border there, the aortic area, now aortic stuff in the second right intercostal space, right? But you're getting into the heart, and you get cardiac dullness, then you get into pulmonary resonance from there. So if I get that, if right around the sternal border I've got dullness, and across the sternum I've got dullness, but as I leave the sternal border and start heading toward the clavicular line and I get pulmonary resonance, does that tell you the heart is not enlarged? Does that tell you that the heart is not enlarged? Yes. What would tell you that the heart is enlarged?
Dullness.
You start the mid-clavicular line, and you take one step over, and you've got cardiac dullness right there. Or maybe in the mid-clavicular line, you should do this, maybe in the mid-clavicular line, you've got dullness right there. Is that the way that's supposed to be? The heart's not supposed to be out there. So if you get dullness other than along that sternal border, that tells you the heart is enlarged. The silhouette of the heart is enlarged. Does that make sense? So this is what we're going to, I'll need a volunteer. So I'm going to, who's my other, yeah, Elizabeth, right?
Yeah.
Elizabeth, I do have to have you, I do have to have you lie down for me, and have you put your head up here, and just feet down there. And you can bring your, you can do this to, relax. So we've got sternal notch real quickly, the angle of the lead, good, and third intercostal space right here. So here we go, and let's see if I can produce a good one. Real quiet, guys, okay? Real quiet. Resonance? Yeah, how about in the back? Can you hear it? Now, take a stroll by the examination area, the laboratory there, and I'm going to be at that little desk there, watching these examination beds here. And is it fair that if you do that, I should be able to hear it from my little desk area? You've already been in the lab, right? So you know what I'm talking about, true? Yeah. So if I can hear it, you get the full credit, no deduction. If I can't hear it, you're not gonna get the full credit. And I want you, these work study students and Professor Palladino, she set up hours with you. This is the weekend I really take everybody up on things. You agree? And then they'll say, oh yeah, that sounds good, that's gonna pass, that's gonna pass. All right, so if you can hear it in the back, did you, honestly, did you hear it in the back? If you can hear it in the back and I'm producing it, then I'm only expecting you to go less than halfway. That desk from the beds are about to this first table, right here, this first desk. So I think that's reasonable, do you? All right. So let's try it again. What's my note? What did you just hear?
Resonance.
Resonance, listen. You hear a change?
Yeah.
I'm gonna compare. Listen to the cardiac dullness. I'm right over the sternum now. Cardiac dullness. Back to going resonance. Do you hear it hollower? This is sounding slappy or thuddier, all right? So here we are, over the sternum now. You're hearing resonance come back in. Let's compare this to this. Hear a difference? How about in the back? Can you hear it? Cardiac, close your eyes. In the back, close your eyes. Tell me what you're hearing.
Dullness.
Close your eyes. Really resonant on this right side, huh? What are you hearing?
Dullness.
You got it, good, thank you. All right, makes sense? All right, and then, so let's look at the value. Guys, let's look at the value of percussion. The value of percussion is that I'm able to identify if the heart is enlarged. On the lungs, I'm able to identify if I've got a tumor. Let's talk about lung cancer. I've got a nasty tumor. A patient of mine has a nasty tumor on this right lung. And as you come down through, you're supposed to be getting pulmonary resonance in this mid-clavicular area, and there's a big patch of dullness that you're getting. That tells me there's some solid stuff going in there. Could I get it with pneumonia? Would I get dullness with pneumonia?
Yes.
Yeah. Could I get it with a pulmonary effusion, where I've got this big fluid, like a blood pocket going up there? Yeah. How about a collapsed lung? The lung collapses. Hyperresonance, or even maybe tympany. Definitely hyperresonance, depending on how bad it is, maybe even tympany. The tympany that goes with that. Okay? Goes with.
So we're just going across the third?
Only the third. Guys, we could do the third, fourth, and fifth, but that wouldn't be too polite on some of our patients, right? Do you follow me? I know that you're still students. You're not yet nurses, so I wouldn't put you as a surrogate patient if someone chose you, or a roommate that's coming in through the third, fourth, and fifth intercostal space coming through there. Do you see how that just might not be just good? You follow me? So, if you can do it in the third, you can produce what I'm looking for in the third. Can you do it in the fourth and fifth as well?
Yeah.
Yes, you can. Okay, make sense? Good question. Good question. All right, questions on this cardiac thing? Questions on the cardiac thing? All right, Joseph? Oh, time again, okay. Let's, all right.